Welcome to ANA Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. On today's show, we'll focus on functional neurologic disorder, or FND, a wide range of conditions including non-epileptic seizures and functional weakness, dystonia, and tremor. These conditions are common and can cause serious disability. But what are these conditions exactly? What has functional neuroimaging and what have other tools taught us about their pathophysiology, diagnosis, and treatment? I'm joined today by Dr. Sara Finkelstein, a neurologist and specialist in functional neurologic disorder at Massachusetts General Hospital. We'll talk about cutting-edge research in FND and how this research can help us to improve care for these patients. Welcome, Dr. Finkelstein. So good to have you here on ANA Investigates.
Great to be here. Thank you for having me, and thank you to the ANA for taking an interest in this topic.
So to start, Dr. Finkelstein, I was hoping we could just briefly summarize the clinical spectrum of functional neurologic disorder.
Yeah, absolutely. So as you mentioned in your lovely intro, there's a wide range of different types of symptoms that patients with FND can present with. I would say in clinic, I see people that fall broadly into three categories mostly. The first would be patients with functional seizures, or what you otherwise might have heard referred to as non-epileptic or psychogenic seizures. The second category would be patients with functional limb weakness. And the third would be patients with functional movement disorders, which could be things like tremor, dystonia, or gait disorders. In addition to that, there's also symptoms involving problems with functional vision, speech, swallowing, as well as functional cognitive disorders.
So it's a pretty wide spectrum. What do we know about the biological underpinnings of functional neurologic disorder? Do these conditions share the same biological underpinnings? And what have we learned from functional neuroimaging about the pathophysiology of these conditions?
So that's a really great question. And I think it's an interesting question because you're asking about the biological underpinnings of FND, whereas maybe 30 years ago, we would have been talking about the psychological underpinnings. So I think one point that I'd like to emphasize kind of up front is the way that we're conceptualizing this disorder these days is not as something just that's purely biological or purely psychological, but we're trying to get rid of that false dualism, if you will, and just treat it as a brain disorder more broadly. In terms of what we've learned through studies over the last 20 years or so, there's a lot that we've learned, but there's also still lots that we don't know. Things to keep in mind about studies that are out there, they're relatively small in terms of sample size. So we're talking tens of patients, not hundreds of patients, and not a lot of them are replicated. When we look at the literature as a whole, I think what becomes really evident is that FND is a multi-network brain problem. What I mean by that is there's probably multiple different networks that go awry with this disorder. That can involve things like the attention network, predictive processing, self-agency, and the limbic network. Again, when we look at the literature as a whole, a few themes do come out. So one of those major themes is when we look at how emotion processing relates to sensory motor activity. And there have been some nice studies done with functional neuroimaging showing that the functional connection between the emotional processing centers, or the amygdala and limbic system, have increased connectivity with the sensory motor networks, meaning that emotion might have more of a role to play in how somebody experiences sensation or motor movement. Another theme that comes out is when we look at the self-agency network. So self-agency is your belief that you have control over your own body, basically, and what you do is because you have that sense of control. So when we look at certain areas related to self-agency, such as the right temporoparietal junction in FND patients, there have been studies that show that there's some hypoactivation there, and that there, again, may be altered functional connectivity with the sensory motor cortices in the opposite direction from the limbic system. So there's actually less connectivity between those two areas. So the bottom line is it's complicated. There have been lots of studies showing, deficits in motor planning, intention, execution, and in some cases inhibition. There have been studies looking at attention dysregulation. And really, we're still in the process of trying to put all these different pieces together in a cohesive manner. But we think that there's many different areas of the brain involved.
Great. So, let's talk in detail about the diagnosis of functional neurologic disorder. How have the diagnostic criteria for FND changed in recent years?
So there's been a really important shift in the past few years, especially with the changes that have been made to the DSM criteria. So when we moved from the DSM-4 to the DSM-5, there were two major changes, I would say, to how functional neurological disorder or conversion disorder, as it's listed in the DSM, is diagnosed. One of those changes is that we no longer consider FND to be a diagnosis of exclusion. So instead of that, we look for positive rule-in diagnostic signs on physical examination in order to make the diagnosis of FND. In the case of functional seizures, what you'd be looking for is semiological features that are consistent with a functional seizure as opposed to an epileptic seizure. So that's one of the major changes. The other major change is that you no longer need a stressor preceding onset of symptoms in order to make the diagnosis, which I think is a nice change because it more accurately reflects the lives of patients, where not all of them come to you saying, I recently had a physical injury or I recently had a very stressful situation. Some of them don't have any of those types of triggers immediately precipitating the symptoms. So it's just a nice way of reflecting more of a broad experience for our patients.
Is it accurate at this point to think of FND as conversion disorder?
Yeah, so that's a great question. The idea behind conversion disorder is you've got some sort of psychic trauma or subconscious thoughts or ideas that are very distressing to you. And in order for your brain to dissipate that energy, it changes them into functional physical symptoms. It's a term that has a basis in psychological constructs and was really promoted by Sigmund Freud's ideas about FND. So I would say that can sometimes be useful to think about for certain patients, but really that's looking at FND as a purely psychological phenomenon, which is, I think, not how most of us in the field conceptualize it anymore. Personally, I don't use the term conversion disorder. I prefer FND. I think patients often prefer it just because it doesn't imply a certain etiology. That being, a psychological etiology, as would be implied by using the term conversion disorder.
So talking more about diagnosis of FND, clinicians will often use exam maneuvers to try to distinguish FND from other neurological conditions. How reliable are those tests? Are there other biomarkers that we can use to try to diagnose these conditions instead of relying largely on physical exam?
I would say first and foremost, FND is a clinical diagnosis. In terms of the exam maneuvers that we use, it depends which exam maneuver you're talking about or which semiological feature of a seizure type event that you're talking about. Some are more reliable than others. For example, a Hoover sign for functional limb weakness in the leg is fairly reliable. I mean, it's actually a pretty good sign. Other things for functional arm weakness, for example, where you get drift without pronation, less reliable. Same thing for functional seizures. If you see somebody who has forced eye closure during an event that lasts longer than 2 to 3 minutes, that's got generalized movement where the patient maintains awareness throughout and stops and starts, that's very consistent with a functional seizure. So I think you can feel pretty confident about the diagnosis. Ultimately, what you really want to be seeing is multiple positive rule-in signs, ideally. There are really no good biomarkers for FND at the moment, unfortunately, either because, we've tested it and it doesn't reliably tell the difference between FND and something that isn't FND, or because it's just not practical to implement. So, for example, there's some EMG features that you can use to look at functional movement disorders such as functional myoclonus, but not a lot of people who do EMG actually know how to do those. So it's not something that we could really practically implement across the board. Similarly, there's no functional imaging, even if that was widely available, where we have robust signs. So it remains a clinical diagnosis. for the most part, which hopefully for neurologists doesn't make them too uncomfortable, because there's a lot of physical examination that we rely on in much of neurology.
That's great. We won't have time on the podcast to talk in detail about the treatment of all of FND, but what is your general approach to treating FND?
Treatment for FND is essentially brain retraining. It's just that we come at it from a couple different angles. So one of those angles is through rehabilitative therapy. So that would be either physical therapy, occupational therapy, or speech and language therapy, depending on what types of symptoms the patient has. The other way of brain retraining is through psychological therapy, and usually we're using some sort of cognitive behavioral therapy there. Certainly, I think every patient needs either a neurologist or a neurologically minded psychiatrist to follow them longitudinally. So one of those two people should be involved long term. The patients that I tend to send to psychiatry are ones that I think have comorbid psychiatric conditions that are not being adequately treated and may be helping to perpetuate symptoms. So if I see somebody with generalized anxiety disorder or major depressive disorder that I think could use a medication adjustment, that's who I would tend to send to a psychiatrist. With regards to sending patients to psychology, and I'll include in that, a lot of our patients actually see social workers in order to get mental health therapy, which can be effective as well. A lot of patients probably do benefit from that because there is a psychological component to the symptom generation and perpetuation. But I wouldn't say as a blanket rule that everyone necessarily needs to see a psychologist. It does depend on the patient and in terms of what you think is going into the generation of their symptoms and their perpetuation of their symptoms.
And is there any newer evidence as to the best types of treatment for these patients? What have we learned in the last couple of years about treating FND?
So there's actually been consensus guidelines published about how to treat FND from a physical therapy, occupational therapy, and speech and language pathology perspective. Those are all available in the JNNP, or the Journal of Neurology, Neurosurgery, and Psychiatry, all published within the last 5 years or so. And they're really great guidelines because they're super practical with respect to how to manage patients based on the different types of symptoms they might have. The first one that came out was the physical therapy one, and it really turned a lot of traditional thinking about this disorder on its head. There has been some trials done that are smaller. Grossly, when we look at multidisciplinary therapies, pretty much any trial has shown a positive result. So minimization of symptoms with multidisciplinary therapy. There's been lots of smaller trials looking just at physical therapy, most of which do show that it's helpful for motor symptoms. And then there's been some trials looking at psychological therapy and CBT specifically for functional seizures, which do show some improvements with respect to things like quality of life and symptom burden.
So what advice do you have for providers who are referring patients with FND to other specialists?
Yeah, so if you're referring your patient to either rehabilitative or psychological therapy, the important thing is you want to make sure that the right kind of therapy is being done and the right thing is being focused on. So in the case of psychological therapy, just referring to a psychologist or social worker without any sort of instruction of what you'd like them to do is probably not going to be helpful, because often what happens in that case is the patient goes and does a rundown of their week and doesn't really focus necessarily on the physical symptoms. So what I would suggest is directing that conversation a little bit more. There's some really nice tools available on the internet to help with that. The book that we tend to use in our clinic is called Overcoming Functional Neurological Symptoms, a 5 Areas Approach. It can be used as a self-help book or actually with a therapist, and it's CBT based. Similarly, if you're sending somebody to rehabilitative therapy, you want to make sure that the person you're sending them to is familiar with FND, and if they're not, I would really recommend providing them with a copy of those consensus guidelines that I spoke about earlier from the JNNP.
So to conclude, Dr. Finkelstein, what are some exciting areas of current and future research in functional neurologic disorder? Thinking here of some of the junior researchers in our audience.
Yeah, so I would say there's lots of low-hanging fruit when it comes to FND research because there's still so much that we need to learn. There's lots that can be done with functional neuroimaging with respect to understanding symptom generation and maintenance. Um, Interestingly, actually, the National Institutes of Health just put out a call for research funding proposals for the development and validation of FND biomarkers. So that's become a bit of a push in the field. And then, in addition to the more basic science stuff, I think there's lots of clinical research actually that's really ripe for investigation. We've got these great consensus guidelines for treatment of patients, but we haven't run a lot of trials based off of those guidelines. There's lots of work to do in the field. I think it's an exciting field because if you look where we are now compared to where we were 20 years ago, there's been just huge change in our understanding of this disorder. And I suspect over the course of the career of somebody who's just starting in neurology, that we'll see the same, where we're going to see a lot of change in our understanding and methods of treatment of FND going forward.
Well, Dr. Finkelstein, thank you so much for joining us here on ANA Investigates to talk about FND.
Thank you so much for having me. It's been really fun.
That was Dr. Sara Finkelstein, neurologist and functional neurologic disorder specialist at Massachusetts General Hospital. To listen to past episodes of ANA Investigates or to submit an idea for a future podcast, visit myana.org. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Dr. Megan Ritchie. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.